Good evening and welcome to this public briefing of the Standing Committee on Social Development. My name is Janeway Allen Armstrong and I am the MLA for Mufi and Cliche Government, Chair of the Standing Committee on Social Development. I will now ask members in the room to introduce themselves, followed by those online. Thank you.
George Nersey, I'm the MLA for the Mackenzie Delta.
Kieran Testone, I'm the MLA for Range Lake.
Danny McNeely, MLA for the Satu region.
Julian Morse, MLA for Frame Lake Yellowknife.
And those online now, starting with Ms. Yakalaya.
Cheryl Yakalaya, member for the Det'anchogh. Thank you.
Hi, it's Shauna Morgan here, member for Yellowknife North. I apologize for not being there in person. I am still a little sick and worried about being contagious. Thank you.
Thank you, members. Today we will receive a briefing from Premier Simpson and Health and Social Services Minister Lisa Semler on Consolidated Workplan towards Health and Social Services System Sustainability. Please note this meeting is being live streamed to the Assembly social media channel. I would like to remind all members and witnesses to direct all questions and comments to myself as chair and to wait to be recognized before speaking to help us have a smooth meeting. I will now pass it over to Premier Simpson and Minister Semler. Please proceed with your presentation. Premier.
Thank you, Madam Chair. I'm pleased to be here tonight to provide committee with an update on the work related to healthcare system sustainability. With me from the Department of Executive and Indigenous Affairs, our Associate Deputy Minister of Healthcare System Sustainability, Terence Coutre, Executive Director of Healthcare System Sustainability, Jennifer Young, and my Ministerial Special Advisor, Freddie Bergeron. There are other witnesses who Minister Semler will introduce. The landscape of health and social services, the health and social services system is changing rapidly. In tonight's appearance will provide committee a short summary of the work currently ongoing, not just from the Sustainability Unit, but from the Department of Health and Social Services and the Public Administrator of the NTHSSA as well. Madam Chair, our officials have prepared a short presentation that summarizes the work currently ongoing on these different fronts. With your permission, I would like to turn to Minister Semler for her opening remarks, and then we could proceed into a presentation. Thank you, Madam Chair.
Yes, please proceed, Minister Semler.
Thank you, Madam Chair, and sorry I can't be there in person. Again, too, like Shauna, I, no matter how much hand washing and hand sanitizer, the virus got me. So good evening, everyone, and thank you for the opportunity to meet with you today. I am joined today by Alan Duty, Deputy Minister for the Department of Health and Social Services, and Dan Florazone, Public Administrator of the Northwest Territories Health and Social Services. I know there's many staff in the room, and I'll have Alan, if he can introduce them once I'm done my speaking notes, just so everyone knows who's in the room, as I'm not there. When I accepted this role, I knew meaningful change would require clear understanding of what was working and what was not, and where change was most needed. It also requires alignment with available resources that we have. Over the past 2 years, we've heard from staff, Indigenous leaders, patients, families, and MLAs. They told us about the fragmented care in the Northwest Territories, especially I've heard loud and clear from the smaller communities, the stress of medical travel and racism and Indigenous residents face when accessing care. That feedback has helped shape 3 key priorities for our health system, which are modernize medical travel so it supports care rather than adding stress for patients and families, strengthen care in small communities by providing greater support for our community health nurses and developing a model that ensures continuity of care as close to home as possible, and embedding cultural safety and anti-racism throughout the system to ensure every resident receives equitable, respectful care. These priorities reflect what I've heard that matters most to Northerners. They also align with this government's mandate and the priorities that I was given as minister. To be clear, this work is not happening in isolation. It's been done in close collaboration between the Department of Health and Social Services and all three Health and Social Services authorities, and is supported by the Healthcare System Sustainability Unit, which is helping us plan for long-term stability. These partnerships ensure that decisions are informed by operational realities and community voices. Progress is happening across the system. We've taken steps to reduce reliance on agency nurses and provide more resources to remote cabin communities. We've also secured federal funding to support key priorities like addictions medicine, detox, cultural safety, and medical travel. These are just a few examples, and there is plenty of work ahead. Frontline staffing shortages remain a challenge across all jurisdictions, and we continue to look for solutions to address burnout amongst staff. Your role remains vital in guiding this work and ensuring it reflects the realities of the people we serve. As leaders, our responsibilities extends beyond our accountability. We must collaborate to address the challenges and build a sustainable health and social service system for residents. Equally, we must champion our communities and their leaders, creating the conditions that attract people to live and work here while proudly sharing the improvements, progress, and successes as they unfold. I look forward to the discussion today and sharing our progress on the work in more detail. Thank you, Madam Chair.
Thank you. Okay. Thank you for the presentation. Who does the opening remarks? Okay. Deputy Minister of Health, please proceed.
Thank you, Madam Chair. And before I start with the presentation, I just wanted to introduce the members of the staff that are here with me from the Department of Health. So Jeannie Matheson, Sarah Chakowski, and Kirsten Berg are ADMs within the department, and Haley Mado-Young, who is my senior advisor. Good evening, everyone. It is a pleasure to be here with the collective leadership team from the Department of Health, Social Services, from the Health System Sustainability Unit, and also from NTHSSA. And it's our pleasure to give you an update on some of the ongoing work across the system as it relates to the legislative mandate and to the priorities established by the Minister. I just wanted to note that the topics that are being covered here tonight does not reflect all the work that's being done across the system. There are several pieces of significant work ongoing in the department and the authorities that are focused on improving access to care. I would also like to just take an opportunity to acknowledge the staff within the system that have helped, are working on these projects with us, and also all the frontline staff across the territory who are delivering healthcare services. We often end up in times where we talk about things that are necessarily we need to work on to do improvement, but those staff work hard every day to deliver those programs, so I'd like to acknowledge them. So the presentation it's going to be delivered by myself and the public administrator and the associate deputy minister for the Health System Sustainability Unit, and we'll each talk a little bit about what's going on in our areas, and then we'll take time for questions at the end. So from the Department of Health and Social Service perspective, I'm just going to give an overview of the three priorities that the minister has set for the department and some of the work that's ongoing under each of those priorities. It's important also to note at this point that when my colleagues present, there's coordination across all three entities that are present here tonight, and actually in the other health authorities as well, in the delivering of some of these programs and the work that's ongoing in those programs. That's done. We have weekly meetings, DMCO meetings, to talk about some of these coordination issues, and we also have bi-weekly with all the entities to talk about how we're moving some of this work forward. So just so you know that it is being coordinated across the system. So first and foremost, the medical travel modernization. And before I talk a little bit about the work, I just want to acknowledge that the system last year supported over 20,000 movements of individuals to be able to receive care throughout the territory or at a territory. So it's a different amount of effort that it's ongoing. However, we all know that there is always room for improvement, and this is one of the areas that we always receive complaints from clients on things that we could do better. So the work in the medical travel modernization is really focused on achieving some key objectives: improving efficiency in benefit administration through streamlined processes, ensuring consistent application of policy, improved communication and notification with clients, as well as financial sustainability of the program. As I mentioned in my earlier remarks, there are other pieces of work that are ongoing in the system that will have positive impacts on the medical travel system, such as delivery of dental services closer to home and the small community work that's ongoing. These areas will bring services and access close to home and will take pressure off the medical travel system. And as the minister has stated several times, this will also take pressure off the health system in the larger centers. So the key drivers of this work ensure equitable access to care, the delivery of the program in a financial and sustainable way. So this is being managed through co-led steering committee, and there's a work plan developed to evaluate the system that includes activities such as the current state process mapping and a value stream activity to streamline the process, the creation of a medical travel manual to ensure consistent delivery of services, and improve communication and knowledge sharing with the public and also internal staff. The small community model care was presented in some detail earlier this week, so I'm just going to highlight a couple of items. So first of all, the drivers. The small community model care review was conducted because of challenges in delivering consistent health service in small community health centers, with health centers frequently on reduced or emergency services. Also, the national nursing shortage has led to difficulty in recruiting registered nurses to work in community health centers. So the team began this work with brainstorming sessions with representatives from the Department of Health and Social Services and the authorities. And emerging out of that work to help guide jurisdictional scan and environment was focused on licensed practical nurses, paramedicine, with enables identified such as virtual care and nurse practitioners. So the recommendations were based on the finding of the review, and with 5 key recommendations that have improved to strengthen care delivery in small communities. Paramedics and LPNs are already being used in the NWT health centers, but the use has been inconsistent with various roles and responsibilities and levels of integration. We need to fine-tune, standardize, and formalize the use of these roles, which will include developing standards and policy, training supports, and change management plan. The recommendations are not intended to replace the community health nurse-led model of care, but rather support and strengthen it by optimizing the roles of other care providers and building more resilience, standardized system of care. Once this work is complete, it will support primary health care reform efforts. The Cultural Safety and Anti-Racism Division work to support health equity and anti-racism across our system. The goal is to create lasting change by fostering respectful, inclusive, and an accountable system that is better serve Indigenous communities. This work includes the delivery of cultural safety and anti-racism training to staff across the system, regular engagement with Indigenous governments through the Indigenous Advisory Board to provide updates and gather feedback on our various programs and services, review and advising program areas across our system to ensure the programs and policies reflect culturally safe approaches. Recently, there has been work to update our approach to cultural safety and anti-racism training in partnership with the Center for Equity and Inclusion. This updated training will begin to be delivered in the 26-27 fiscal year. There is also work to update an equity tool to support program areas in consideration of the potential impacts of the programs and/or policies. This team is supporting community, culture, and innovation to plan and facilitate a traditional health gathering that will take place in February 2026. So that concludes my portion of the presentation. Madam Chair, and if it's okay for you, I'll pass it over to the Public Administrator.
Yes, please proceed.
Thank you so much, and thank you, Premier, for this opportunity, Minister, MLAs. I appreciate this opportunity to provide an update. Meetings have continued quarterly. But by the way, before I proceed, I should just recognize Kim Riles, CEO of the Northwest Territories Health and Social Services Authority, and Amy Lamb, who supports Kim. So I'm very, very pleased to have them here with me today. The regional wellness councils continue to meet, and they continue to be very active in bringing forward issues that matter locally. The chairs continue to meet with me quarterly. So much like their previous role with Leadership Council, we've continued to meet quarterly, to engage, to understand what the issues are. Our latest few meetings have been about listing out all the priorities that have been brought forward. There's no doubt there's been frustration about progress and making progress in a timely way. What the minister has tasked us with is focus, identify priorities, and set out actions around these priorities. What the Regional Wellness Council chairs have done is they've taken all of the issues, territory-wide. This includes Det'anchogh and Hay River, so territory-wide, and they've come up with a list of 12 items that they would like to move forward. So these are 12 themes. There are other items other than the 12, and I would put these in the category of items that are all of government, or whole of government, or multi-agency, multi-ministry, multi-departmental. So what those items are things like the illicit drug trade. There are items that would include housing. So as regional wellness councils, they don't see their bounds being just simply that which the health and social system delivers. And what we've got is we've got another list that we're tracking. We're wanting to make sure that we can connect with other agencies and departments of government, other agencies within the regions, other superintendents, and start to move these intersectoral collaborative efforts forward. We also know there's a lot of good work that's going on government-wide, and that's under the leadership of this current government. We'd like to tap into that and make sure that we're present, we're supportive. We may not be the lead, but we can certainly participate and contribute to it. So with the 12, the understanding of the chairs is that if everything's a priority, nothing's a priority. So what they've done is they've come up with their own top 3. Now you're going to recognize these 3, and you'll recognize them because they're highly aligned with your priorities. You'll see improving access to care, which is a priority of the Legislative Assembly. They're also highly aligned with the minister's priorities because she participates and attends at least twice a year, and she was with us in June in our efforts to confirm these top 3 with the RWC chairs. Those 3 are improving access to care, cultural safety and anti-racism, and we heard from the Deputy Minister of Health and Social Services, the good work that's going on. Also changing the organizational culture. And what we're talking about is a bit of success, innovation, and celebration of those innovations. So I want to talk to all 3 of these. So just to be clear in terms of working together and thinking and acting as one, the people at this table with the minister and the premier are tasked with nestling in our priorities to make sure that we're actioning at every level, whether it's a sustainability unit at a high level, looking at the future of health and social service delivery, to the department at a policy level, at a strategic level, to the NTHSSA and other authorities to make sure that we put the boots to the ground to be able to action these steps. So these are only 3, some important contributions. First of all, in improving access to care. What we decided to do in terms of being on the ground is to take a step which was going and following the patient on their journey. The reason why this is important is that we have a tendency in governments and in organizations to be siloed. So by following the journey of the patient as they travel from health cabin to health center to hospital to the south for care, it gives us an opportunity to identify gaps, to understand their experience. And this included not only traveling to health cabin communities as a starting point with the team from NTHSSA and the Department of Health and Social Services, but also to travel with patients on that journey throughout. We are compiling our findings, and we're not sitting here waiting to put together a plan that seeks approval and then we start actioning. We've actually set out 30, 60, and 90-day action plans, and we've so far completed 80% of that plan as we speak. Sorry? Yeah, so I'm sorry, I might have missed something, but so we've completed 80% of that plan. There's still work to be done. I don't want to enter into a precursor of some great announcements that are coming our way. This is a Det'anchogh demonstration site project. We believe that what we've learned in a short period of time in the Det'anchogh can be applied in every region throughout the territory. We do have plans for scale and spread. Our next step, I hope before the end of this meeting, to talk about where to next. So in terms of that, we've taken a look at areas including infrastructure, equipment, training, protocols, point-of-care testing, virtual care. We've reintroduced areas like point-of-care testing in cabin communities. We've looked at add-ons to our current capacity and capabilities around virtual care, so audioscopes, stethoscopes. We've entered into training, and that training has been extended beyond the Det'anchogh, training the workers in health cabins to include all health cabins throughout the territory. The staff of those health cabins are pretty excited with the supports that they're about to receive, and I'll leave it to the minister to talk in the question and answer about some of the great stuff that she's been involved in. She went on a more detailed site tour and just came off of a visit, and I hope it hasn't made the two of you ill, but I know that those visits are so important and so critical to moving things forward. On the cultural safety and anti-racism front, and the third priority, which is medical travel, sorry, that was cited under access to care. We've looked at those issues. We've got an action plan specific to the Det'anchogh, and we have an opportunity here to be able to move those improvements, albeit in a very concerted way, starting in the Det'anchogh and then spreading everywhere. So just to be clear, our plan is to go everywhere with this improvement work. On cultural safety and anti-racism, we've got a people strategy that is currently in draft form. We're going to be presenting to the committee and seeking your assistance with completion of the document. It is in draft form. It's in a position, we're in a position now to capture what the minister heard through various town hall forums with staff, what we've heard through our visits with every region in the territory. And by meeting with staff and physicians, we've tried to summarize and capture those themes within the people strategy. So what the people strategy is really is, it's a human resource strategy. And ultimately, we know success by the fact that we have a strong, safe, culturally safe environment that's staffed to a high extent by Indigenous staff, and we're working towards these aims within that strategy. There's also been a great piece of work around cultural safety design, the collaborative team report, which is honoring the voices of Indigenous people. What's refreshing about this report is it names it for what it is, the racism and the need for change within the system. There's a series of recommendations, 13 actions for change, And we're looking forward to continuing to work on each of those action steps to move this important work forward. What I wanted to just touch on last is our change in organizational culture. At a previous committee meeting, I mentioned to this group that I was thinking about launching, then it was just a bit of a germ of an idea, but 52 and 52. It was the idea behind 52 staff-inspired changes. Sorry, I'm not very good at the keeping up with the slides. Thank you, Deputy. If you just keep going. Next one. Sorry, the slides aren't moving, but I'll just keep going. So 52 and 52 is inspired by a change that a staff or staff group has brought forward each and every week. Today we're at week 23. We posted to our website 22 ideas that come in and are posted every Friday. And these ideas are intended to be small changes that have big impacts. The biggest impact is at the end of the year, we'll have 52 improvements that have occurred. And I'm pleased to say, and we haven't summarized all of these, but I can tell you it's everything from dental care to locum feedback, to primary care, to cystoscopies, to cultural knowledge, to health center delivery, to occupational health and safety, healthy family programming, you name it. Now, we're going to conclude, and I will conclude my first-year work plan at the end of December. The idea is I'm going to release a second-year work plan. And that second-year work plan is going to focus on the key areas that are still undone from the mandate that the minister has set for me. There have been many milestones, but year 2 is really about working with the sustainability unit in the Department of Health and Social Services around medical travel, about moving the Det'anchogh improvement work to Yellowknife, and bringing in a deep dive into primary care access and improvements that are necessary in the city of Yellowknife. I'm going to be looking at moving 52 and 52 into a greater focus on red tape reduction and streamlining. This will involve the forms and processes that get in the way of staff and physicians being able to provide care. So it may take time to complete. It may be a step that they might view as unnecessary. Those are the types of improvements we're going to begin to pivot into. I'm going to have a risk management plan that's completed. I'm going to look at the main focus is going to be working myself out of a job. So the handoff to the new governance body, I've got recommendations that will be completed this month. They will have to be reviewed before they are released. But the aim here is that next year, I want to be in a position to not only have the new approach stood up, but the training necessary to take place, the change management to be undertaken, and for that handoff to occur so that I can depart and leave the place I was born, but with fond memories of being able to work in this territory. Thank you. I'm going to turn to Terrence with the Healthcare Sustainability Unit.
Okay, Premier?
Sorry, thank you, Madam Chair. So the clicker isn't working for the slides. Is there an option to change the batteries, or should we just proceed as? Oh, we got it working. All right, thanks.
Terrence, have I gone too far?
One back, please. Thank you. Thank you, Madam Chair. Good evening, members. It's nice to be here again with committee to provide a short update on the work of the Health Sustainability Unit. As members will recall, we provided committee with a written update earlier this summer where we discussed the completion of our preliminary review, which was really the first phase of our work. That preliminary review was important on a couple fronts. It helped us understand two important questions. The first was an understanding of the current suite of health and social services programs that are being delivered across the entire system. And secondly, how are those programs and services being resourced? The key takeaway from that initial work helped us identify 7 priority areas to inform the unit's next phase of work, which has already started and will continue into the coming months. The 7 priority areas listed on this slide do not cover everything that the health and social services system does, but it's certainly a good start. And at the top of that list is supportive living and bed-based addictions. The work in those 2 areas have already started and is going to continue into the coming months. There has been some initial work already underway in the areas of long-term care and out-of-home care. The remaining priority areas of physician services, out-of-territory hospitals are on deck, and we look forward to starting that work in 2026. With all this in mind, the work is currently ongoing to be staged so that we could potentially have some recommendations around defining core services in time for the 2027-28 business planning cycle. And in concert with this work and part of our initial commitment, we still aim to develop a continuous improvement plan that will help to monitor and track sustainability beyond the life of our unit's work. That work is not started yet, but it is expected to pick up in the fall of 2026. One question that we often get, Madam Chair, with our work is how will we define what services should be core to the NWT? And members will recall again from previous updates that our work is grounded by a monitoring and evaluation framework, which consists of 2 phases. The first is an operational assessment, while the second phase is a sustainability assessment. This diagram on slide 14 helps us understand the 2 approaches. Under the operational assessment, we look to current delivery specifics, how the program and services are operating, how they're funded, and how they compare to what other jurisdictions are providing. This work also considers things like legislative and policy authority, utilization rates, and standards of care. Under the sustainability assessment, we then test the current delivery against future needs and analyzing different options to make the delivery of our programs and services more sustainable. For each program or service, the recommended sustainability option may be different, and in every case, it will be based on evidence and can include one or more of the options presented on this slide. So taking both assessments together will help us formulate recommendations around defining core programs and services in the NWT and create awareness where opportunities to improve sustainability exists, map out how to implement change, and measure that success. Madam Chair, in terms of next steps, it's really about staging our work to review those 7 priority areas over the coming months. Our ultimate goal is to have recommendations formulated that potentially could feed into the 27-28 business planning cycle next fall. We're going to continue to work closely with our colleagues at this table, as well as the Hay River Health Authority and the TCSA. Almost all the work we do by our unit is done in conjunction with program staff. However, in order to ensure coordinated oversight, I think Deputy Duty mentioned this earlier, we do meet with deputy heads and the CEOs at least bi-weekly to ensure progress and then to ensure our work is coordinated and aligned. So with that, Madam Chair, I think this is the last slide. I will turn it back to you. Thank you.
Thank you. Thank you for the presentation. No, I will not ask the member if they have any questions. MLA to start.
Thank you, Madam Chair. I guess I'll get the ball rolling. Thank you very much to staff. That was a lot of information, so I expect we'll have a lot of questions, and perhaps even need more time to go over this, because we're dealing with 3 very large, complex projects. But I guess just off the top, like we've seen the other day when we received the small community model of care update as well, it was a lot of discussions around planning, around evaluating what we can do, and building a plan for kind of eventual actions that are more tangible. So, Madam Chair, I guess off the top, my questions are, to date, with all the work that we're putting into this, how much money has been saved in terms of finding efficiencies? Have the rates of staff recruitment and retention improved in any tangible way that you can demonstrate? And how many patients feel more culturally safe compared to rates of complaint before, which I would hope we would be able to ascertain that through the Office of Client Experience. But I would like to know if we have any metrics that show since this work started, we've made tangible improvements that show these efforts are working, and in particular, the efforts of the public administrator. Thank you, Madam Chair.
Okay. Thank you, Emily. To start, Minister Semler?
Thank you, Madam Chair. For when we look at the savings when bringing in the public administrator, what the first thing that he was tasked with was to produce a budget. He did produce a budget, and there was a significant demand that we needed to be balancing our budget, and that doesn't mean, you know, when we put in for forced growth and things like that, when we needed to balance it in a way that it's not going to impact patient care. And so what I'll do is I can turn it over to the public administrator to show a lot of the work where he did work on that part and the first part of the budget. With the staffing issue, he's done a lot of work with one-on-one, I think, working with the physicians within the authority. However, with the other parts of the recruitment, it's a two-part thing, because the problem that keeps rising is that, you know, the health recruitment sits within finance. And so we can do all the things that we can do in health, but that piece lies within finance. So if I can turn it over to the public administrator.
Okay, Mr. Floresville?
Thank you so much, and thank you for the question. We're at early stages. We've made some investments, so we've spent some money. We've spent what I would suggest is the spending is an investment. I mentioned to you some of the add-ons that we've made at the health cabins to some of the telehealth capabilities. I mentioned some of the point-of-care testing that we've reintroduced. I've also mentioned some of the training that we've been doing and providing at the health cabin level. Over 600 charts were reviewed, and on that review, the initial look was that 30% of the trips, the medical travel that did take place, is avoidable. That's not to say we're going to be able to mine that immediately, but in looking at that chart review, and again, this is confidential, this is looking statistically from my point of view, the experts that took a look at the chart have developed a plan. That plan directly relates to avoiding those trips that are avoidable. So what it would look like is more care closer to home. What it would look like is care that's culturally sensitive. What they did was they spoke to citizens. They spoke to members of the regional wellness councils, to patients as they arrived in the health cabin. They went to the place where care is being provided. They spoke with the staff of that, and I have a full summation of all the interactions that they had, all the dates that those were occurring. Now, this is process. It's also anecdotal. What we have, or we do have surveys, and we're working on further surveys of staff. We're looking at further feedback from regional wellness councils, and I said I'd do that on a quarterly basis. I'm interested in tapping into and not only monitoring medical travel and potential savings, also the theory behind all of this is that if we can provide more services closer to home, we can prevent some of the overburden that's occurring in Yellowknife, the overcapacity issues, the high volumes. It leads to quicker discharge, and our hope is that it doesn't, can avoid the transfer in the first place. So you're about to receive a release. It's still pending. Top secret, don't tell anyone. We've got it on our website, and we've got our first tranche of 6 indicators that have been posted to that website. They include the capacity at the ER within Stanton. They include some of the very important metrics around lab utilization, around outsourcing. Medical travel is included within some of those early indicators. Now, this is going to be far more robust, but here's my instruction to the team. Don't wait for perfect before you start posting. Let's get some indicators up. Let's test the waters. Let's have people look at it. Let's debug it before we start to announce anything about it being done. So I can feel the invisible jabs from behind the room that I've just announced something that's the biggest secret going. It's sitting on our public website. So if you want to take a look, you can. Is it the full answer to what you've talked about? I got to tell you, it's still short of that. We still have more work to be done. In order for us to give you a number of how much we've saved, what volume we've avoided, we've actually got to set some targets. What's the target? What's the time frame? And my next activities in the new year will be to establish a select few around these priority areas of select few targets and time frames for you to be able to compare it to. This is risky business because I put it out there. You get to, and the public gets to evaluate whether we achieved what we set out to achieve, but it's important work. So 30% is my notional right now, but that's a very small 600, not so small, but it's a very concentrated look at the numbers, and I look forward to setting broader goals right across the territory.
Thank you. Emily, to start, do you have a follow-up question?
Yeah, I was hoping that we would actually have some numbers to share and not so much what you're doing. I understand what you're doing. I'm looking for those results, but I mean, the public administrator's comments at the end, I think, are clear that we're going to have some targets and we're going to meet them. I'm just surprised that, after, it's not like we're building this system from scratch or it was like, completely administratively challenged, and I'm just surprised that we aren't able to set those targets, that wasn't part of the work of the first year work plan, and that we can't come back and say, we're making progress, here's our progress. Again, it feels like we are in a position where we are preparing to make progress, and that progress will be made at some point in the future, hopefully by the end of this government. But if it's anything like the cultural, the small community plan, we're only going to see results next government, and perhaps after that. So it's important, and the accountability piece, I agree with you. I don't think it's risky. I think it's what we do. It's what we do as a public government. We need to be accountable to the people we represent and we serve. So until we have numbers, I have to assume that these things are not improving because I can't gauge them, and I hope that that's not the case. In your list of priorities from the wellness councils that filtered up to NTHSSA, in the public administrator's list of priorities, I didn't see staffing as a priority. And staffing is the key to most of our challenges. That's everything we hear, whether it's national nursing shortage, whether it's physician shortages, whether it's the working conditions having changed for the profession in 2025 that are different from before, that are preventing posting health professionals to small communities. Staffing, in my mind, is the way to unlock the solution to our problems. And practitioners, I can tell you, still feel very much unheard, even this far into all the advocacy we've done, whether they be physicians, nurses, or allied health professionals. So why isn't staffing one of those 3 priorities? And I mean, I know it's underneath all the priorities, but I think it should be number 1. Thank you.
Thank you, Emily. To start, Minister?
Thank you, Madam Chair. The priorities are set by the members, the chairs of the Regional Wellness Council. So their priorities are what they are seeing as users of the system. And so we're not going to dictate where they prioritized. And this and the things, when you say that there's nothing happen, there's many things happening. There's ongoing changes, constantly adapting. We do have shortages, and even with this small community model of care, the reason why we're utilizing LPNs and paramedics, because they're already being used in our system. So they're already being done. And so we're trying to look at ways to make sure that we can make sure that when they're going into the system, how do we put them into our system? Because paramedics are not currently in the they're not public servants in the system. So are we working towards that? However, right now they are being used in the system. So, and then when we look at the small communities, yes, there's lots of things going on. There's a whole bunch of work going on right now within the health authority to look at access to care in the capital, and there'll be some things rolling out soon. And so as these things come up, we have a budget. We're maintaining within our budget, and that's, right now we have to try to maintain and do the things that we need to do and make the changes that we're going to make within the budget that's allocated to them. And so that's the piece that the public administrator and the CEO have been having to continue to balance within that, so that we're not continuing to creep up these huge deficits year after year. And so by making some of these improvements, like the medical travel improvements, those are going to bring the cost down so that we can actually use those dollars to put towards something else. Thank you, Madam Chair.
Thank you. MLA McNeely, do you have a question?
Yes, thank you. Thank you, Madam Chair, and thank you for the presentations. It's glad to see some deadline or progress is being made, and we're going to see a rollout of that progress here by the end of this year. And my question is similar to the previous member on identifying progress and helping you to analyze the recommendations so you can improve on efficiency. Was the previous Auditor General's report recommendations reviewed to incorporate into your future plan moving ahead? Thank you, Madam Chair.
Okay. Minister Simler? We can't hear you. I think you're on mute.
Sorry, I'll turn that over to the Deputy Minister.
Deputy Minister, please proceed.
Yes, Madam Chair, and thank you for the question. Yeah, so, just in general, any recommendations from the Auditor General, once accepted, are incorporated and into work plans to try to achieve what's been recommended. That's just practice of the department.
Mr. McNeely, do you have a follow-up question?
Thank you, Madam Chair, and thanks for the reply. It's good to see that we're using all the tools in the toolbox to improve. And I never heard prevention in all presentations. And I think that this is an ongoing thing, having preventions. Preventions reduce costs. And to measure the progress, a spreadsheet was shared by my northern colleague, and it still shocks me to some extent to say that the medevacs for the SAW-2, I just focused on the SAW-2 after the information was provided. In that region, seen 448 medevacs in 3 years, so 36 months. So we can do the math. It's a huge issue. They don't identify for what reasons. So it's a combination of several cases, elderly folks needing attention, and accidents, and overdoses. I know of a few because I spent some time up there in the emergency area. So just using that, we can move ahead and say, okay, another 24 months from now or another year from now, that came down for these various reasons that we're doing. So we're measuring our progress using 448. So I just throw that out there as a line item. And my question is that, is there a standard equipment audit and inspection that is done to all these cabins and the regional centers? I ask because the dental team came into Norman Wells, and being nosy as I was, I went and asked, you know, how are they doing and so on. They were referring to the aged equipment that was there. And so I thought, okay, I'll bring that up at the next opportunity. So I just question, is there a standard routine inspection of the current equipment in our facilities? Thank you, Madam Chair.
Okay, thank you. Minister Sumler?
Thank you, Madam Chair. As dental is not an insured service, therefore we do not have pots of money that pays for and continues to do the upgrade. However, the biomedical team does overlook the current equipment that we do have. However, a lot of the equipment is old and not working, and you know, we're in discussions with Indigenous Service Canada, as we have a contract with them in order to bring dentists into the communities, and therefore when it comes to dental equipment, they had, I think, about 15 years ago replaced a whole bunch of dental equipment, but since then that has gone to the wayside. So where we are in our conversations with ISC is trying to get this dental equipment replaced, and but all the other equipment throughout all of the services that are for insured services, so those ones we have evergreening dollars that we allocate every year to go through and figure out which equipment needs to be evergreened. Thank you, Madam Chair.
Okay, thank you. MLA Morgan? Morgan, do you have a question?
I do. Thank you, Madam Chair. And thanks to the large group for joining us tonight and presenting about all these different aspects. In terms of the small community model of care, excuse me, I've heard sort of two different approaches perhaps that we're taking. On the one hand, we've gone ahead and introduced, you know, there's going to be 2 new nurse practitioners in the Det'anchogh region going into the 4 health cabin communities, and you know, spending a week at a time in each community, and new training for community health representatives, and that's going to have a huge impact, positive impact on the care and access to care that people in those communities have. But I'm also hearing that the priority is to spend a lot of time working on new standards and a new model to figure out how it can apply to all the different communities in the territory. And my pitch, I guess, is that I see the approach of just sort of going to each community and sort of talking to the teams on the ground and trying things, you know, sooner rather than later, rather than waiting for, you know, the design of one grand model or one set of standards that's going to apply to everyone. Because, I mean, even in those Det'anchogh cabin communities, there was a standard or a model. My understanding was that the intention was there was supposed to be a team of nurses and going into each of those communities once per month. But that wasn't happening because of, as I understand it, shortages of staff, especially in Fort Simpson, and then the shortage of staff there meant that there wasn't people to send to the outlying communities, and so it just wasn't happening. So there was a standard, it just wasn't being followed due to this shortage of staff. And so I see sort of a weakness of the approach of spending all this time, you know, and effort to come up with these standards as like, what if it doesn't work because on the ground we just don't it's not realistic in terms of the staff that are available. But instead, what if we talk to the teams in each community, and my understanding from going in and being able to see more of these small communities is that each one is actually different in terms of its challenges, and maybe some actually some of the small community health centers might have some regular, even resident full-time community health nurses there, and the continuity of care in that way is going great, but maybe they need more virtual care support. Others, they might not have any sort of continuity. They might be seeing different nurses every time, and so if there's sort of a revolving door of people coming in, maybe they need more sort of local community health reps or home care workers or something on the ground who can be that continuity and tie. But I guess what I'm saying is that the makeup of each team or what's realistic in each community might actually be different in each community, and maybe that's okay. And if we just start on the ground and figure out realistically what can happen here, especially given that the cabin communities, many of them around 100 people in terms of population. And it seems right now some have community health reps, some are sort of full-time, some are half-time, some have home care workers, some don't. And people can probably tell you pretty quickly in those communities, if they don't already have one of those workers, if they don't have home care workers or community health rep, is there anyone currently in the community who has the skills or interest to do that? If not, okay, what else could we do? Or just to cut to the chase pretty quickly in terms of what staff resources do we have available realistically? What plan can we make that's actually going to work here? So my question is, instead of focusing on the standards and the model to apply to everyone, could we just go right ahead like was done already in the Det'anchogh cabin communities? And could we just go into all of the 9 cabin communities in the territory, and then even all of the community health center communities, and just work with each team and figure out what small staffing changes or additions could make a huge difference in this community, and just do it. Just given that even just one new FTE, these 2 new nurse practitioners in the Det'anchogh, that's this pretty small amount of resources that's going to make such a huge difference. So I'm just anxious to see that kind of difference being made in all of the smaller communities in the territory. I know that was a huge intro, but I'll leave it there. Thank you, Madam Chair.
Okay. Thank you. Minister Semler?
Thank you, Madam Chair. I'm not sure where to start. I guess I just want to be clear right now, while we're doing these standards, and I said it already, LPNs, paramedics, we are already utilizing them in the system. Why we're trying to do the standards is so that right now we have a model and we're trying to supplement the model. We're not taking away, because sometimes with the vacancies, we want those communities to be flexible. And maybe at the end of the day, when they have a couple of LPNs and a paramedic and a couple of chins, that's going to work for that community. And I agree, every community is different. I've traveled into almost every community now except for 4. And every community is a little bit different. And so when we talk about the Det'anchogh journey, that was a specific targeted when we did the what was the need was in that area. As I traveled throughout the territory, it was evident, the MLA from there, we had many conversations about like the lack of services in that community. And the other health cabins, they have regular visits. They have So we already know that in some of the other regions, because as you know, when the health authority amalgamated, they still have regions and they still kind of functioned in their own way. Some had better supports for their health cabins, and they still do. And like Det'anchogh has a nurse coming in from Hay River, I think 2 days a week. And and I think, you know, Sigachik has a nurse, has had the same nurse for probably 15 years, going in there every week, and then she stays there for freeze up and break up. The nurse goes into Colville Lake every week on the plane because there's planes going in unless it's weather. So there, that's why I was saying the focus was on these communities for that one piece. But we are what we're doing is that the model is already there. We're not changing the model of the health centers. What we're doing is we're putting them standards so that way with LPNs in the community, there isn't really a guideline for what they're doing, so they're just kind of filling in wherever the nurse in charge needs them at the time. And it goes back to MLA McNeely, where we need people doing health promotion. We need a lot more focus on that. And when you have the chin nurse that's constantly be pulled into emergencies constantly, well, all the health promotion stuff goes to the side. So this is why we're trying to supplement, so that way it frees up the nurses to do their job, and then the use of the other staff can go and work in these, and they are right now. And I just want to be clear that in certain areas they are already supplementing those models. Thank you, Madam Chair.
Thank you. MLA Morgan, do you have a follow-up question?
Yes. Thank you, Madam Chair. My follow-up would be what I've heard a number of times from community health nurses who are currently or have worked in small communities is that when there are consistent nurses, community health nurses working in small communities, that's actually an ideal model of care that we would do well to bring into regional centers and even the capital into Yellowknife. That model actually works way better than the models we've got in say Yellowknife in terms of primary care. And I have also heard even from practitioners like doctors in regional centers and Yellowknife that they're also sort of yearning for more of a small community style of care in primary care, which would mean, well, from what I hear, adding more community health nurses, nurse practitioners in particular, into primary care in Yellowknife and in Nuvik to really ensure that there is more continuity of care, there's more consistency, that there's people that are really tracking and following patients, making sure people are up to date with checks and immunizations, or and really getting to know the patients over time, which is often really lacking. So the question is, I know that there's been a focus on what to do in the small health cabins. You did mention that the idea was to start looking at some point in the near future at Yellowknife primary care. Before, instead of spending 5 years kind of studying this, if we already know that this is a model that's working and this is what people are sort of begging for, could we go ahead and try really trying to stabilize and bulk up our primary care in the regional centers in Yellowknife by adding more of these kind of small community style community health nurses, nurse practitioners, to increase people's access to care here too. Thank you, Madam Chair.
Minister Semler?
Thank you, Madam Chair. And I'm really I'm really glad to hear you say that, Shauna, because that's what, when we talk about team-based care in the primary care clinic, that's the model that we're trying to look at. Because when you look at it in say, and I can say from when I was in the Beaufort Delta, So every team would be, the team like you would look at like Det'anchogh would be one team, and then sometimes they would have a nurse practitioner there. And so it would be the first person who's most appropriate health provider to see that person. And then if they were sicker, then the nurse practitioner would see them. And then if they were sicker, then they would refer them to the physician that is in Inuvik. And sometimes that physician is coming in on regular visits, or else if they need to see that physician, they'll see that physician through virtual care. And if they need to see the physician in person, then they would go to Inuvik. So that is the model that we're trying to do in the primary care clinic. That's the exact model, just in one space. So that's why I keep saying like it's working in other we've always practiced team-based care in outside of the capital and across Canada. That's how they're trying to reform the primary care clinics to those team-based cares with that same mindset model. Thank you.
Thank you, Minister. MLA Nursu, do you have a question?
Thank you very much for your presentation. My question is around culturally safe communities and staff within our smaller communities. Alcohol and drugs is playing a big part within all our communities throughout the north. It is taking a great toll on our resources, our nurses and other resources within our communities with long hours, being on call after hours. The department has to look at the in-territory facilities, treatment facilities. I know there's a couple in the Beaufort Delta, the GTC and the IRCS facilities that can be used. And, there's a lot of, I've heard stories from members of my community and surrounding areas that they are interested in trying to kick their habit, but some of them don't want to go down south or being culturally shocked down there. So after another area is aftercare for treatment recipients. When people come back from treatment, there's limited access to where they can go to get aftercare. And I know the communities are trying to help these recipients when they come back, to give them support. And, something that has to be looked at, especially for just to minimize the burnout of our nurses. I see it, you hear the nurses going to places where, there may be a lot of misuse of alcohol and or drugs, and it's taking a toll on them. So treatment centers within the north should be looked at carefully. Is there any studies or anything being looked at in that area? Thank you.
Thank you. Minister Simler?
Thank you, Madam Chair. Madam Chair, when it comes to Indigenous culturally, sensitive, programming, and most of the Indigenous groups that we have talked with, they want to be doing these things on their own for their people. And so what we do is we provide them with some funding, and we have multi-year fundings with many of the Indigenous groups. How they run their program, it's not for me to dictate, but what we provide is when someone chooses to want to, see a counselor, and then they work with a caseworker, case manager, and a counselor that usually works with them to find the best programs for them. And we still hear that many residents do not want to stay in the north while they're in active treatment. They do want to come back and they do want to partake once they come home into programs. And so most of the conversations that I've had with Indigenous leaders in all regions want to be the ones leading those programs. They don't want us coming in and doing those programs. So this is, but in the other piece of it is they come back, and when I've asked, like I've had a lot of people say there's no aftercare. We have counselors. We do have counselors in most of our communities. We have different resources. However, most people, when they come back, they say they have no housing. And so this is an issue in our territory. When people do have addiction, sometimes they lose their housing, and then when they're on the journey to be sober, then they come back and they're back in that homelessness. And so I know that in Yellowknife, we started with a transitional housing. One opened and one will be opening soon in Inuvik. And those will be the starting point where we can assess if this is working or tweak it, and then we can expand it. And thank you, Madam Chair.
Thank you. MLA Nursu, do you have a follow-up question?
Yes, thank you. I just brought that up because the GNWT runs the liquor stores, I know in Inuvik, but nowhere else, and the minister's right on the housing availability within each of the communities. It is prevalent and evident within my communities in Mackenzie Delta, and when dealing with alcohol and drugs, it has a negative impact on all the departments within the GNWT. My other question is related to medical travel, escorts, accommodations. Is there any, how much involvement is from the Indigenous governments to look at boarding homes for their respective community members, like maybe GTC and IRC can look at something maybe along with the SAT2 to look at boarding homes, because there is a shortage of hotels within patients traveling to Yellowknife is for dental purposes. And when will we see improvements to the regional centers in terms of dental practices? Looking at maybe other jurisdictions where we can send our patients for dental care, is that something maybe can be looked at? And one other thing related to dental is I've been informed, directly. I phoned the dental office or dental team here in Yellowknife to make an appointment. They said I had to get assessed by someone, and I asked who. They said the health centers. The health centers are already overworked. They have their own schedule now. They're being used as secretaries for the dental team, and I was informed by the nurse in charge there that they weren't very satisfied that they're doing this type of work where they can be focusing on their own work. And when will we see some improvement, or is there any light at the tunnel in terms of dental care for regional centers within the Northwest Territories? Thank you, Madam Chair.
Yes, Minister Sumler?
Yep, thank you, Madam Chair. When it comes to dental, we are right now we're actively working with ISK and the providers, and I think where we are is this: as soon as we get the green light on this dental equipment that we can go forward with and get all that out, I'm hoping that it will be, within the next, in the next quarter, that we can have a better answer for that. However, I think the referral pathways right now is one of the pieces that this has been highlighted when we were traveling. The nurse referral is one pathway, but the dentist can also fill out the same paperwork and submit it if somebody calls the dentist. And so there's this confusion, and I think the piece is that because when COVID happened and all of the dentists, couldn't practice, and then when people started going to dentists, they started flying, and everybody started flying, and then the dentist kind of put up um they put up a list of things that they would want to see back into the communities, and all of the dental equipment was one of them. And so we were working collaboratively with Indigenous Service Canada because they're the ones who pay for the dentist to fly into those communities. So a RFP goes out and the dentist bids on that, and then they bill fee for service for all of the people that they see in those communities. However, we allow them to use the facility, and then we'll keep all of the equipment in the room. So we're hoping within the next quarter we'll have a better answer on that. And back to your piece on the boarding homes. So those boarding homes go out as a RFP. So the one in Yellowknife is run by, I think it's actually a owner. It is Aboriginal owned. And then the one in Edmonton is, I think it's a partnership between Kitikmeot, Larga is in partnership, and I think GTC is also partnership on that. And when they bought the big new hotel, so the piece around medical travel and the overcrowding, yes, there's tourists, but that was never taken into when we got the new contract for the Kaskori. It was just never meant to house dental. We never calculated the amount of need for dental because it went from, a few hundred dental to a few thousand dental now that travel every year. And that is all covered by Indigenous Service Canada, the people that travel, majority of them. So those things are kind of highlighted with the conversations that we've had with IS to make sure that if you buy the equipment, it's a lot cheaper than the amount of money that you're spending sending everybody to Yellowknife. So thank you, Madam Chair.
Okay, thank you. MLA Yakalaya, do you have a question?
Yes, I do, and thank you. Thank you as well to the team there that provided this presentation for us. There's so many questions. It's just not sure, like the minister, not sure where to start. Okay, and so my first question is, in your opinion, for the health cabins, is this whole system that you're creating going to cost much more, as there's already staff in place at these health cabins? And how can these health cabins support residents with mental issues? Specifically, like with addictions, because right now you're talking about getting people from the health cabins into Stanton or for to receive more care. Is that going to be more of a cost because you're looking at from, when you did the Det'anchogh journey, is there going to be more of a cost associated with this? Thank you.
Thank you. Minister Simler?
Yeah, thank you. The cost difference, I believe, would be we would in my opinion, we're gonna see savings as long as we have people working in the communities. There's going to be less people having to travel. They're going to have their chronic disease managed better. There's going to be less need for them to travel as much. For mental health and addictions, I know that for providing that type of service, we do have dedicated staff in each of the regions, and they're not necessarily always in all the communities. However, they do virtual appointments. And if you want more detail, I think Kim is in the room and can probably provide.
Yes, Kim, please come up.
Thank you, Minister, and thank you for the question. So the intention around the the cabin community work that we're doing out in the Det'anchogh is it's everything that we've done to date is within current resources. So we're spending the money we already have to change, but trying to make changes to the approach to the way that we're delivering service, including improved training, et cetera. Some of the goals, as has already been said, is to hopefully make an impact on reducing some of that travel in and out of the cabin communities for really basic care that should be able to be better provided out there. So a good example of that tangibly would be to, on the training plan for those community health workers in the next few months is to actually get them drawing blood. Basic blood work. So if someone would previously have had to go into Fort Simpson for a blood collection, we might actually just be able to do that out in the community once the staff are trained to do so. So that should reduce the movement of that patient and eventually, like I said, some cost savings. On the mental health services, part of the training plan for those community health workers that we've been working through are actually some topics related to basic supports for mental health. But overall, increasing our focus on the use of virtual care, so having those NPs available both on site and virtually, for example, to help support folks that may be struggling with mental health or other conditions to be able to, provide more timely access to that first level of primary care. Getting our community health workers, again, more comfortable using virtual care to support clients when they come into those health cabins. So like the minister said, if there's a mental health counselor in Fort Simpson who books an appointment with a patient, having that community health worker feeling more comfortable using the technology to actually support them through that visit should help to enhance their access and the timeliness of their access to care.
Thank you. MLA Yakalaya, do you have a follow-up question?
Yes, I do. And if there is going to be extra cost in the future, what would that cost be used for? Thank you.
Ms. Wells?
Thanks. One of the interventions that has been recommended out of the small community work has been around ways we can support acute care stabilization of those patients out in the smaller communities with kind of some resources that could be deployed at a Fort Simpson for kind of more rapid on-site stabilizing care pending a transport. That would require investment of additional resources. So that's one of the things that we've identified as a future piece of work, but it is going to need some further analysis because it would be additional costs. So at the time that we're ready to potentially consider that, we need to ensure that we have all the sources of information to support what would be an additional investment.
Okay. Thank you. I do apologize. Minister, do you want to comment on this?
That was good. No, I guess what I could say is that, when we start to see care closer to home, and I always have to give kudos where it is. Cheryl has been hounding and pounding the table for, health promotion, health prevention. Danny has said it. And that is key to bringing our costs down, because if you have care closer to home, people are getting, they're seeing their practitioner, they're getting the right pills, they're having their chronic disease managed. Some of them probably don't even know that they have a chronic disease, and so getting them assessed, getting them regularly seen, these types of things will reduce the cost on our healthcare system, which then we can use on other things. And so that's kind of what right now it's we're spending, and but where we are is, this is kind of the thing is we have to start, and Shauna had said this, we have to go in, this is where we're starting at the health cabins, and some of this work that we're doing on the small community model of care, we are having those conversations in the health center to say, what is it that you need? We've even talking to some of the social workers. It's like, if there's one thing that you could have, what would it help you in this community? And so those are the things that when we were on the ground, when we're visiting, when I'm going with the leadership through the health leadership through these meetings, and that's where we bring back and we can try and make some of these better changes, because they're coming from the people that are there working in the system.
Okay, thank you. MLA Morse, do you have a question?
Sorry, I
But we weren't operating our own mics. Thank you. Yeah. Okay. I mean, I would just say my first piece of feedback here is coming into this presentation, there's so much information being presented to us and there's so much we could ask about tonight that it's just way, way, way too much for one briefing. We've got effectively 3 different organizations in front of us, all doing different work, all interrelated in the healthcare system. And I understand the desire to bring all of that together and present it to us in a cohesive way, but ultimately I'm just finding it quite overwhelming. And so, yeah, without going into a huge preamble about all the different sides, I think what is most important to the average resident is what we're doing related to primary care and what we're doing to improve access to healthcare. I think in that sense, so I'm going to focus on the work of the administrator for now. It would be incredibly helpful if the work of the administrator could be summarized in simple and direct terms for the public and for MLAs for that matter on an easily accessible webpage. I found bits and pieces. I found the updated work plan. I think that is the piece I'm looking for. But to get to a question, Mr. Florzone mentioned that there are 3 different plans and then went on to say 80% of the plan had been achieved, but it didn't identify which of those plans. Is there a place where we can see those plans with all the various things that are being done? I wasn't able to find them on the website. Thanks.
Thank you. Minister Semler?
Thank you, Madam Chair. I'll say one of the pieces that even the stuff that I just most recently put up on the website, I think, it's trying to get it in the context to put it up online was a little bit of a challenge so that it was user friendly, easier to read. But I'll turn it over to the public administrator because I know that he's been doing some stuff and trying to do it online, and some of this feedback might change how he's doing it. Thank you.
Thank you. Mr. Florzone?
Thank you so much, Madam Chair, and thank you for the question. I agree entirely. Even if you were to look at the most recent work plan update, it's a lot to go through. And what I'm hearing, if I'm hearing it correctly, is we need a narrative that says, here's what we're working on. And not only what we're doing, but the vision around it. So I can say this piece of work related to the Det'anchogh is what I was referring to when I said 80% complete. These are operational plans, not strategic plans. These are the things that were observed, and they're as small as this training to this person. 80% of that work plan is completed, 20% is left to do. On the website, we haven't had as much disclosure of everything that's going on. And I think it'd be helpful, and it's always this balance, as you're aware of, figuring out how much is just right. We can always have an opportunity for people to click on information and get to more detail. But if I can sum it up in a more readable way that the public and others could read, I'm certainly committed to doing that, and I'll make it part and parcel of my work in January. So describing what's going on in more depth, but again, having it summarized and communicated in a way that it holds together. Now, I just wanted to, just for clarification, you've heard a lot today, and you've heard 3 different perspectives. But one of the things I want to be clear on is that our job is to tie these all together. This is one narrative, and the narrative is that we've got a sustainability unit that's working on the big questions. A lot of these are long-term, about what's in, what's not, what's core, what's not. What should we be doing? So I can talk at my level about efficiency of doing something, but at Terrence's level, the consideration is, should we be doing it at all? Or should we be doing other things? So the sustainability unit, in my view, It's a cascade. The Department of Health and Social Services is our policy regulator, strategy setter. So with the minister and the department, we take our lead, and some of this is if there's a 4-year plan around sustainability, 4 to 8 year, 4 to 10 year, there's a 2 to 3 year cycle for the work of the Department of Health in terms of policy and thinking through. They're doing environmental scanning. They're trying to figure out what and how we should be doing what the sustainability is defining as what we should be doing. For us, it's boots on the ground. Like, we are taking all of this and we're putting it into operations. We're making sure that there's good communication with regional wellness councils, that there's a solid connection, and it's a challenge, there's no doubt, connecting, engaging with staff, with teams to be able to do this. But what we want to be able to do, and I'm sorry that maybe I got into a bit too much detail and overloaded, but I think what it comes down to is we want to be able to tell a story that shows how this knits together. It might be clear in our minds, but for the public, and maybe for MLAs it's clear, but for the public, I think they need a story that kind of ties everything together. MLA Morgan said something was really key. She said, I want to see more action. And that's what we're hearing from the RWCs. So here's what I would argue for, is both and, not either or. That we need action in the immediate, and that's what I've been a big, strong proponent of. But we also need policy. We need strategy. We need the thinkers that are looking at the horizon. So we can do both at the same time. I'm obviously really captured by the opportunity to hit the health cabins. And if you want to know what the vision is, the minister's vision is we're going to cycle through the health cabins, through the health centers, through the hospitals, through the south with tertiary care. We're going to continue to cycle through, and it's not a one and done. It's continuous, and it's everywhere. So we're continually looking, assessing, evaluating, engaging, and making the improvements that are necessary, and not waiting for some master, I don't know, consultant or someone to come in and tell us what to do.
Thank you. MLA Morris, do you have a follow-up question?
Yep. I think I'm going to just, I think the difficulty that all of you are facing, everyone that's presenting for us tonight, is you guys are doing very, very complex work. It's very clear to me that it's very complex and that a lot is going on. The difficulty for me is that on any given committee week, I have a couple hours to look at the healthcare system. And there's a bunch of other systems I have to look at. So unless I get something that is like effectively, as it's put, explainable to a child within maybe a 2-page briefing, I don't really know what's going on. And I think that's true for the average citizen as well. So I would just say that the challenge that you guys have is boiling this down and explaining to us in extremely simple terms and to citizens. So I would suggest that maybe some of the public goals you could put out there are things that are going to mean something to people. We are working to achieve, anybody can get an appointment in front of a doctor or their healthcare team within 2 weeks. That's one of the goals we're trying to achieve. Here's our progress towards it. Not the whole background of all the different things that are being done to get to that goal, but that's the goal that we're working towards. Or emergency room wait times are currently sitting at about an average of 5 hours. We're trying to bring them down to 4. Here's our progress towards that, and this is when we think we can hit that goal. So simple things that are tangible for the public, I think, is what's going to help us understand if the system is improving. Because I think the difficulty I have here is if I'm trying to communicate this to citizens, if it's not tangible, it's very hard for people to believe that something is changing when they go to call for a doctor. And I'll just speak to my own experience. If I call a doctor, sometimes what I'm told is there's no appointments to give you. What do you mean? Like, can I take one in like 4 months? No, you're just going to have to call back in a month or 2. That was the last time I tried to book an appointment. And I think I have a lot of constituents that are in that position. So all the this big long presentation that we're getting, if that's the answer that people are getting on the phone when they're calling to book an appointment, I don't think they're going to feel like we are improving access to healthcare. So I would say I'm happy to see all the complex work. It is hard to pull from this presentation exactly what's going on, and I think one of the difficulties is that we're trying to do a lot in one presentation tonight, so I'm trying to parse out what the HSSU is doing, and okay, so it's hard for me to even come up with specific questions, but I'll go back to Mr. Testard. I mean, I think one of the most important things is staffing. I note that in your work plan, Mr. Florzone, in the most recent version of the work plan, I can pull up the improved stability of the health and social services workforce. That item is listed in red. It's an in progress, but it's not on schedule. Can you give us some updates about what we're doing to improve staffing, recruitment, and retention, and just improve the number of people that we have to facilitate appointments?
Thank you. Minister Simler?
Yeah, thank you, Madam Chair. One of the challenges that this is the ongoing conversations that I've had with the public administrator is that within health recruitment and within staffing, we're not in charge of that at NTHSSA, and that's who oversees it. And so we have these conversations, and so we will be doing the briefing with the MLAs on the people strategy, and that kind of has a lot to do with the recruitment. That is the recruitment and retention, and the reason why we've had to kind of go back on this, because what we heard from the staff, what we heard from our town halls was more multifaceted of other departments. So we had to have conversations with different ministries in order to create the framework for our people strategy. And with that, I think where we are with, so I just wanted to be clear on that piece right there, is that sometimes we have this struggle within the health authority where we are looking at it inside the authority. And I think that's been clear is that these are the pieces around education and trying to do more and trying to support the staff more. And I want to go back to the other piece that you had said, and I think this kind of goes to the bigger issue. And we talked about this, and I've talked many times with the public administrator and with the regional wellness councils. And one of the things that we continue to hear, and we've talked with the staff, is that when people are calling for a physician, they call for a physician, and then the physician time, and why team-based care is the way it is that when you call for an appointment and you're on a team or you are assigned to a team, then they would have you see the most appropriate person. And if then you needed to see a physician, because we've heard from the physicians to say that, they can't do everything. So this is why this team-based care model is putting community health nurses, putting nurse practitioners into the health centers. I'll turn it over to the public administrator.
Mr. Florzone?
Well, thank you very much. The red is now green. I just haven't updated since September the reporting. In fact, what I hinted at is that my work plan is largely complete in year one. What's going to be released is an update of exactly the progress made in year one, anything that's carried over into year two, and there's plenty. But there is a particular focus that I outlined to you on year two. I would say, if you were to just simplify all of this, you could lay out the priorities of the health system: health, human resources, primary health care and its access, medical travel. It's not, we don't have to make it so complicated. And I think what you're advocating for, which I'm agreeing with, is maybe there's a bit of a simplification of messaging. I also hear from MLA Testart that, setting a target and a time frame. Here's our measure, here's the baseline, here's where it's at. Setting a target and time frame is really important work. And I'm committed to doing that in year two of my performance plan. In the work plan, the problem is it's a lot of stuff. It's a bunch of processes and plans to plan to plan. And what we need is action. So I'm committed to converting that. There will be a bit of planning, like risk management, I think is something that good work is happening. I want to release a risk management report so that MLAs can see it. I think the boots on the ground and getting to talk to real people is important. The data is also important, but if we can have the data and the narrative, that's gold. I think the people in the health cabins get it. They know what improvements are being made because they're witnessing it. But in Yellowknife, they're not getting it. I want to tell you this, Yellowknife improvements are occurring constantly, but they're not fast enough. Not for our appetite, not for your appetite. So we're going to make a concerted effort to accelerate our initiatives in Yellowknife. I'm committed to, between January and March, to the minister to accelerate the work in Yellowknife in exploring and engaging the teams, including physicians, but all care team members, in idea generation, in analysis, in measurement and target setting, and improving access to primary care. So we're going to work on medical travel, we're going to work on primary care, and we definitely need to work on health, human resources. I'm really pleased on the physician front with where we've landed, because it was rough waters, really rough waters. But we're at a place right now where interest-based bargaining has been indicated as where we're headed. And this is thanks to the Department of Finance. We're going to be at that table. We're going to be putting interests on the table. And between that and engaging medical staff and teams, we're going to think about what we're doing in rural. Just like what was talked about outside of Yellowknife with the Det'anchogh demonstration project, we think there's learnings, but we also think the context is quite different in Yellowknife, and we're ready to apply those learnings. I'm more than committed to come in and give you more detailed briefings on any of these matters. This is a hard one for us to coordinate. I took the oxygen out of the room, probably said too many things, but I want to tell you that we're committed together to working together towards these and to keeping the committee and government and the public up to date. There are problems here that need to be solved.
Okay, thank you. Thank you, Mr. MLA Hawkins. Do you have a question? Okay.
No, I'm good, Madam Chair. Thank you. I had trouble taking the mic or mute off. Thank you.
Okay. Okay. Thank you.
Thank you for asking.
Okay. I do have a question too as well. Minister did say in her comment, in her opening remarks that you secure federal funding to support these key priorities, just the addiction medicine, detox, cultural safety, and medical travel. But with the detox, we don't have a detox center and we don't have a treatment center in the north. And she also said that, well, some of the programs that the Indigenous want, that they apply for funding because they know that some of the treatment down south, due to cultural safety, there's a language barriers for many of our residents, so they don't want to go south. But some of the other programs, but both of them, it doesn't work for everybody. Some of the people that wants to, get sober up, they know that on the land it's not going to work for them, so they prefer treatment. So there's two of that, and when people identify this, and we all want people to succeed because we know costs money to send people somewhere and costs money to apply for programs. So with that in mind, I know when people go south to a treatment program, a lot of them ask for extended care, and there's aftercare. And we also heard from my colleague here saying that there's no aftercare for when people come back from the treatment program, and there's no housing. So a lot of these people that goes for a treatment program down south A lot of them request for aftercare, but there's no money for that. So, and then you said that, and then Minister did say that, and Public Administrator also mentioned too, is that you work with the regional council, setting these key priorities. So, which is good, So I just want to ask, to check, to see if any of in your work with a regional council, did anybody identify the need to support aftercare in the south where people receive the treatment? Because there's more support there for them than coming back up north or coming back to their communities, because there's no support, even in any of the small communities where there's no mental health workers and there's no housing. So there's nothing for them. So I just want to ask to know if if that is part of the plan for people wanting to go for treatment, because I know that there is success, people going for treatment if they're sober 1 year. And a lot of them choose to stay there, but it is expensive. Thank you. Minister Semler?
Yeah, thank you, Madam Chair. Sorry if I can't get through. With the aftercare, that's not something that is funded out of territory aftercare, and that's what we have, because we wanted to make sure that if we were going to spend money on aftercare, that we were going to make sure it was in the north. And so that's what the THARPs are, the transitional housing and recovery programs that we have. And the one started in Yellowknife, and we have another one that's opening shortly in Inuvik. And then with those two opening, I know that we will take an assessment of those as they are running. Maybe I'll turn it over to Alan.
Alan?
Yes, and thank you, Minister, and Madam Chair, thank you for the question. Yes, so the intention is, as the Minister said, one is open in Yellowknife and the other one is intended to open in Inuvik here in short order. And we're going to do an assessment of those programs so we can learn from them. And then the intention after that would be to expand it across the territory so that we can provide that type of support for folks that are returning to the territory after treatment.
Okay. Okay, some of this, the people that I talked to, that ask for, even for a short period of time, like 2 months. And I know that, I'm speaking from for my region, because we know there's a lot of social issues. We have a lot of addiction issues, and we don't even have a transitional home. So when people go out for treatment or even go for on-the-land training or on-the-land program, they come back, especially the unhoused people. They have no place to go. I'm sure it really helped that the programs do, it helps them, but they go back to the same old, and they go back to the warming shelter, and it's never-ending problem. So that's why I know Yellowknife is, they just recently opened one, and in Inuvik they have one. So I just want to ask if transitional center was mentioned in the work somewhere within this, for the detox or treatment in Klitschko region. Thank you. Minister?
Thank you, Madam Chair. At this time, no, and I believe it's, I think the work that the Klitschko is doing on their own, I believe that they are championing their own vision of how they want to do things in the Klitschko. We haven't we are only dedicating, we've only got funding for the two facilities right now in the territory. And then with detox is actually, it is running. It's not, when you think about detox, in some other places, they usually are a part of a treatment facility. Ours, the detox where we have allocated the funding into the hospital model. So when people are working with their caseworker and they know that they need to go through detox, then they can be admitted and go through detox safely. I can turn it over to Kim and she can tell you how the program is rolled out so far, because it's going to expand, I believe, as well through the department. I think Cammie's working on community with NTHSSA.
Okay, Ms. Rouse?
Thank you, Madam Chair. As the minister said, over the last, during this fiscal year, there have been two dedicated detox inpatient beds available at Stanton for direct admission from communities for folks that are identified who wish to detox. And it's been determined that they need medical supervision to do that. Not everybody who's detoxing actually needs to go into a hospital. Most detox can be supported at a community level. But to be able to do that most effectively, the work that the minister referenced is now kind of underway. There have been a number of community mental health nurse resources that have been funded in regions to be able to have that expertise and skill set to be able to safely support that community-based detox. But in the event where that's not safe for an individual, there is that referral pathway available to the inpatient beds at Stanton when needed. The uptake on that so far hasn't been high, but the resources available for when it is needed.
Okay, thank you. Yeah, this is a good presentation. I really do appreciate, and members do appreciate too. But I will allow for one more questions, because department did not say anything. He didn't say that, we were not given any time. So I will allow second round of questions to our member, and but to be clear and concise. And so I'll start with Mr. Tester.
Thank you, Madam Chair. And I think the first round was probably due to the complexity of the presentation. So in the last assembly, there was a great deal made of the government renewal initiative, and that it would be the first time an inventory of all government services, and that would allow the ability to find efficiencies within the system, reduce the size or reduce the red tape and the cost of government. GRI has now become a tool for budgeting and is not the transformative initiative it was billed as. What assurances can you give me and members of the public that HCSS is not just another GRI, and after you're done your work of creating the inventory, that it's not going to sit on a shelf as a tool for management planning and budget planning and not actually going to achieve what we're promoting as system-wide change that's going to make a more efficient and effective healthcare system. Thank you, Madam Chair.
Thank you. Minister Semler?
All right, I'll direct that over to the Premier, as that sits under him.
Yes, Premier.
Thank you, Madam Chair. So a comment was made earlier, why are things taking so long? We're not building the system from scratch. And if you've done any construction work, you know that renovations are way more complex and take way more time than just building something from scratch. And so the work that we're doing with the Healthcare System Sustainability Unit, it is digging down into the current state of things. And that information is valuable on its own as it emerges. But as was pointed out by the public administrator, it really is for the long term. And so there is a plan to take that information and create recommendations about what services are being offered, how those services are being offered, the cost of those services, whether or not they're sustainable. And that type of information, I see it as valuable as being used in every submission from Health and Social Services or from the Health Authority for future funding for any system changes. It is offering us a base level of information that we've never had before. part of the reason that I really wanted to initiate this unit is because for 4 years I sat on cabinet, and much like the comments we've heard today, I had no idea what was going on with the health system. I didn't know where positions were, where the cost drivers were, and those are questions I continuously asked for 4 years. And so now we're going to be in the position where when those questions are asked in the future, as they will be, as they are every year, we're going to be able to have answers for it. So it is something that is going to be useful. Will a future government just put it on a shelf and never use it? Then that's a possibility, but we definitely have a use for it here. Thank you.
Thank you. Thank you. Do you have a follow-up?
Yeah, only to say, and I'll make this one very brief. You know, I appreciate that you need to that these are complicated and you need to look at things, but and develop plans to implement things. But if we don't have an action plan that is costed, that is time bound, and that is measurable, I don't know how we can, to Mr. Morse's comments, like how we can explain our progress. And if things are so complicated that, like, I mean, I can follow along, but I mean, my rule of thumb is if you can't put it in a tweet, then you're not effectively communicating what you're doing. And if you're not effectively communicating what you're doing, and people feel it kind of tangentially when they get services they didn't have before, that's fine, but that's not the experience we're hearing. Like, we're not hearing from our constituents, oh, by the way, everything's going great, we don't have issues with the healthcare system, we're seeing lots of improvement. We're hearing the exact opposite. And then when we come to these briefings, there's nothing to measure, right? There's more plans and timelines for completing those plans and completing planning documents, but a plan to plan is not a plan. We need actions, and we need measurable actions that we can hold our own selves to account to make sure we're meeting our mandate. So until we see that, and this is not the first time I've said this, that I told the Minister of Health when the plans, when the public administrator was appointed in the first place. And I just want to reiterate that until we have that, we're not going to be able to assess the effectiveness of what we're doing here. And we won't be able to reassure the public that things are actually improving. And the staff as well, because that is the linchpin of the system, and they are still feeling very much unheard, and that progress is moving far too slow based on the significant challenges they face every day in their work. And those are the people I'm thinking about most, because we cannot have a health system without doctors and nurses. Thank you, Madam Chair.
Thank you. Premier?
Thank you, and I have shared the members' frustration on the speed of change. Up until not that long ago, you know, I was thinking, boy, we're almost halfway through this government, and I'm not seeing the changes that I was hoping to see. But we're at a point now where those are starting to come to fruition. We are developing a budget for next year, and there's going to be some things in that budget that are going to make improvements in things like medical travel in other areas. And I won't, you know, step on the minister's toes on this one. I'll let her bring forward the good news at the appropriate time. But that type of work is happening now, and we're seeing it. I always like to talk to the minister about her vision for healthcare because it's the system that we all want. And her trip into the Det'anchogh, I think that highlighted a bunch of things that can be addressed immediately. And I know she's taking steps to make immediate changes to medical travel, and we're not talking years, we're talking months. The Healthcare System Sustainability Unit, that is longer term, but as the public administrator said, there's changes that are happening today. In terms of communications, I think that the public can probably handle a bit more than a tweet. I don't know if we can get things down to 140 characters here, but I agree with the member that simple communication is not the government's strong suit, and it has never been. I'm starting to ask for just one page, as like the member said, that you could use to help explain something to a child. And so that's the direction that we are going, and I think we continuously need to do better at that. And from what we've heard tonight, I think that we will. You know, when we hear criticism from MLAs, I don't take it as a negative, I take it as opportunity to improve. And so when we hear this type of valid criticism, it's often the kind of things that the minister and myself might say to each other off camera. And then when we hear it here on camera, it helps us push that harder. So coming out of this briefing, I think that we will see better communications and much more simple, straightforward communication as well. We are past the planning to plan phase, and we are in at the onset of implementing some of those plans while continuing to make plans for the future as well. So it is an ongoing cycle, but I'll leave it at that. Thank you, Madam Chair.
Okay, thank you. MLA Morgan, do you have a question? Second round of question.
Yes, thank you, Madam Chair. So this one is about the sustainability unit. So I understand from the materials in the presentation, and it makes sense to me, the aspect of the work that they're doing, which is like look at currently how the programs and services are funded and designed, and figure out if there are best practices or different ways that they could be delivered, more efficiently or better. Sure. But the aspect that has always confused and troubled me is the idea that the big role of the unit is to sort things into core and non-core services. As Dan mentioned, or sorry, Mr. Florzone earlier in this presentation, part of their job is to look at, are there things that we're doing that we shouldn't even be doing at all? And so, I think at least a year in to this unit's work, maybe a year and a half, my understanding is that the unit has already come up with the full inventory of everything we're doing. So my question is, have you been able to identify yet in this big inventory and list of everything we're doing that there are things that we're doing that we should potentially not be doing at all, that are just not non-core, that are not needed? Is there any examples at all that you can give us of things that the health and social services system is offering that seem like extras or frills or just sort of optional that don't need to be offered to residents? Thank you, Madam Chair.
Okay, Premier?
Thank you, Madam Chair. So there is a draft inventory of all the programs that are being offered. And just to be clear, the Healthcare System Sustainability Unit is not going to tell us what is core and what's not core. They're going to make recommendations so that as the decision makers, we can advance this Assembly's priority of access to basic health care. That's really what we're focusing on here, is ensuring that basic health care is available to everyone. And that means looking at what we're doing across the system. If there are things that are above and beyond that basic care that are impeding our ability to provide basic care to people in small communities, in regional centers, and in Yellowknife, then we need to consider whether or not we want to continue putting resources towards those things at the expense of offering basic care. Thank you, Madam Chair.
Okay, thank you. I'll go to Mr. Morse, MLA Morse.
Thank you very much. Yeah, and I just want to be clear, what I'm offering is not what I would characterize as criticism. It's simply trying to help you understand my perspective and that of the public, so you can better understand how to communicate with us and the public. That's how I'd characterize it. I want to similarly switch to HSSU for a second. And the question I would ask is the sustainability unit considering the increasing access to healthcare priority of the Assembly as they conduct their work? And I'll focus on a specific example because you've raised it, and it's one that's important to constituents of mine. The supportive living example. So this is an area which is important to my constituents. I have a number of constituents who access supportive living, and I'll just put it this way. If the unit comes back saying we can't do this anymore, or this isn't core and we don't want to do this anymore, it's not going to fly with my constituents and with me. But I would say that those residents have also given me a lot of feedback, some of which I brought to the floor and brought to the minister, for how things could be done better, more efficiently, more affordably. And some of them have even suggested switching away from the government providing service to becoming a funder so that they can hire service providers. And it's been pointed out to me that in a lot of cases, particularly ones where we have people sent south for care because we can't offer the care here, if we were able to bring them back and give that family a subsidy, they could cut the cost in half. And so there's opportunities for significantly reducing the amount we're spending, but continuing to provide the service. So I'm just wondering if the HSSU is considering those kinds of options and not looking just at what we don't do anymore, but how we can do things differently. Because I think I think that's gonna be the real difficulty when the rubber starts to hit the road on what the HSSU is gonna be doing. If citizens are seeing it as taking services away, I think we're gonna have a lot of political problems, and it's not gonna make its way through an election cycle. And like Mr. Testart pointed out, it'll just gather dust at the end. I don't think that's what anyone wants. We want the system to be sustainable, but we're gonna have to do that in a way that citizens are okay with. Otherwise, like I just said, it's gonna die in an election cycle. So can the unit speak a little bit to how they are considering the need for increasing access to care, or at least sustaining access to care, while they're conducting the important work of sustainability?
Premier?
Thank you, and hopefully MLAs have the courage to do things that might be unpopular, as if they are right for the healthcare system, and whether or not is going to affect their, electoral viability. But for detailed answer, I'll hand it over to my Associate Deputy Minister, Mr. Coutre. Thank you, Madam Chair.
Mr. Coutre?
Thanks, Madam Chair. Yeah, the short answer is yes, we will be considering access to care in the scope of work that we're doing. As part of that mandate commitment, defining core services is a subset under that priority. And the work that we're doing is really trying to look at improving those, as you mentioned, as the member mentioned, improving those operational efficiencies, improving financial sustainability without necessarily sacrificing a level of access to care. And when we went through the presentation deck earlier, I believe it was slide 14 that had some examples of what those options might include. And so that's really part of the analysis that we're doing. We got a lot of data to go through, a lot of work to go through in those 7 priority areas. We're trying not to get ahead of ourselves to jump to conclusions of where we might go with this, but we really want to stress that the recommendations and the work that we're going to be doing really does need to be anchored with that evidence first before we bring any kind of recommendation forward for Minister Semler or the Premier to consider. Thank you.
Okay. Thank you. Minister Semler?
Yeah, and I just want to reiterate what the Premier has said. I think we all know what we receive to have an operating budget. And for myself as the Minister of Health, my budget has gone up. I have gotten some extra funding from the feds, but a majority of that funding does come from within. And so when when we're looking at trying to provide basic services versus some programs that may not benefit, something that may not benefit small communities, but are really important for the capital, and things that are important for the capital might be something in the small communities say, well, get rid of, and so this is why this work is so important, that we need to make sure that we have the analysis done, because we are going to have to make hard decisions, and because we need to make sure that we're sustainable. And some of those decisions, like Mr. Moore said, like MLA Moore said, is that, within our departments, this is why we're pushing to we need to do things differently. Sometimes they may not be the way we've always done it, but we're going to have to take a look at being able to be sustainable and doing things that some other jurisdictions may not be doing it, if it's better for our residents and more fiscally responsible. Thank you, Madam Chair.
Thank you. MLA McNeely, do you have a question?
Thank you, Madam Chair. Mine is not a question, but just looking forward to the, call it the year 1 report. And this committee is going through the sustainable unit information and review. So we're still under review, but I think we all heard tonight, this is a very caring and passionate concern of everybody on the other side. And I think we have enough talent in this room here to design with the assumption that this system is totally broken. I think if we have that aspect, we will look at and take every recommendation seriously. And to review the mistaken identity I was reading in the media on patient X, John Doe was transferred to Edmonton. I think we all know of that. So that's another example. So when I hear the public administrator talking about patient journey, okay, well, that's good. You're tracking, and it makes really efficient results when you're focused on that, keeping in mind that we had John Doe mistaken for somebody else for 3 weeks underneath our care. So recognizing the weaknesses, what we heard, okay, I think we're gonna have enough material to analyze as a committee after we receive your report. Mine is just more of a comment than anything else. Basically saying we're still under review. Thank you.
Minister, do you want to comment?
Yeah, thank you. Thank you, Madam Chair. You know, we have one of the pieces that I know that, you know, despite anything, when people come into our territory, yeah, maybe it's not perfect, but we have excellent staff. You know, we have top of the line, you know, the services. We are in this situation, just like all of my colleagues across the country that are, you know, they're shutting down primary cares and emergency rooms. Every day you see something on the news about this, and you know, here we are, we're this small little population in this huge territory with 33 communities, and we're still plugging along, you know. And I think that's because we have some amazing staff in our system. And as I've traveled, you know, the feedback and everything that they have provided, when I travel throughout the communities, there's not big things they're asking for. So this is why I think we're going to be able to accomplish some of these changes within this next couple of years, especially when it results to these small communities and then this primary care. When the public administrator goes in the next 3 months, you know, the biggest issue that we hear in the territory, we're going to have some things that we're going to be putting forward. You'll be seeing stuff coming up in the new budget that are going to be for improvements in the system, especially in the capital, but will also benefit the smaller communities. So, you know, we don't want to to make sure, like, to say that the system is broken. These staff are working, you know, working hard, and yes, we are trying to come with ways to support them. And there's many people in the system that are working on that. And so I'll just leave it at that. Thank you, Madam Chair.
Okay. Okay, thank you. I'll check before we end. I'll check with MLA Yakalaya if she has final questions to ask. Okay. Okay, I want to say thank you. Thank you to Premier and to Minister and to Deputy Minister, Public Administrator, and all the staff for the presentation. Oh, okay.
I could not press the button in time. I want to say, you know, a lot of my colleagues talked of costing, resourcing, health care, health cabins, addictions, and, you know, human resourcing. And I guess for me, I wanted to understand why, I mean, you can help me in the public understand why is the resourcing held with finance? And one of the key things that I always think about is, you know, to alleviate pressures on our healthcare system, and, you know, namely the hospital in Yellowknife, because that's where everybody goes from our smaller communities. Prevention. I keep talking about that, and you know, health promotion stuff is so important, because without that, we're gonna be going into, we're gonna be, kind of digging ourselves into somewhere we don't want to go with, especially with money. And so prevention and all that stuff. So I for me, like, I appreciate that now the health cabins, and because I worried about the smaller communities and the health cabins, how they were going to help the people in their small communities. So I'm grateful and thankful that they're going to be getting more training, more resourcing, um, and they're going to be in a position to be better able to help their people. And however, like, my colleague Mr. Morris said, we need something that's, simple, so we could explain it to the people, that when we do have our constituency meetings and they're asking us questions about healthcare, what's going on with the healthcare, we need that, um, we need that communication. So, um, with that, I just want to say thank you to the whole team coming in and think about what we said in here, what we're asking. Us regular MLAs are asking. We're looking at treatment and addictions treatment, on the land treatment. How much is that going to cost? I was is there an appetite for having, or has there been any investigations happening into having, like for my community in Fort Providence, we have a seniors home. Is there something that could be looked into, making it into part of it anyways, into a long-term care facility? That's what I wanted to ask about, as well as the health center. Is there going to become a point where we're going to be housing people in the health center, similarly to, I guess my colleague, Ms. Wayallen, brought up was cottage hospitals or something like that in the communities. I would like to see something like that looked into or investigated for the community of Fort Providence, because we service, like, if we had to, Kikisa and the majority of the residents here in Fort Providence, and it could be something to look into. That's what I wanted to say. Thank you, Madam Chair.
Okay, thank you. Minister Simler?
Thank you, Madam Chair. At this time, we're not looking at how to keep patients in the health centers. I think the way that they're staffed, they're not staffed. Any staffing situation that has 24-hour care is going to take. I mean, one line of nurses in a 24-hour care is about 5 nurses, give or take. So in order to staff, to keep people, you need to have 24-hour care. Our nurses now are, even when they get called out, then it disrupts the clinic the next day. So then they have their mandatory rest period. And for long-term care as well, like I know that what we are trying to do is we're trying to provide more home support work after hours and on weekends where it's needed. And I know that there's home care assessments done on clients. And if there are clients that are not currently members of the home care, then they can reach out to the health center, and they can do a referral for an assessment. Because then we can better assess how many clients are actually needing home care in the community, so that we can better allocate that to those communities, so that they're able to stay at home longer. I know that me and Minister Koptana have had many conversations about public housing for seniors, so that, more public housing for seniors facilities, so that we could support them through health by home care, and, and then they'd have better accommodations. There's many different things, but as of like long-term care is nursing care, and so when they get to that stage, they're usually stage level 4 and 5s, and that results in 24-hour nursing care. And so the issue that we have is that we have a recruitment issue. So if we were to try and expand those kinds of services now, when we already are having recruitment issues, the issue is, and I had this conversation with another Indigenous group, was that if we don't have staffing, then we're end up having to send them to other facilities or send them to hospitals when we don't have enough staffing in those communities. And we never want to be put in that place either. So at this time, we're not considering either or. Thank you, Madam Chair.
Okay. Okay, thank you. Thank you. Now, this concludes the presentations, and I just want to say thank you to all of you guys. To all of you, as previously mentioned. And this concludes the public briefing, and I do appreciate efforts are being made, and we look forward to seeing the change in the new year. So thank you for joining us, and until next time.